Good morning, everybody. First of all, let me thank Moon and Beth for preparing this case and sharing it with us. It's really very good practice to do case presentations in medical education because that can, give you an idea about how to take care of your patients and how to review your practice. And that can be in the form of mortality and morbidity. So serious cases that you may think maybe we have had the chance to do different approach. This could be morbidity. So we routinely do, M&M cases on monthly basis in our practice just to review the system that we work in, and if we have to take different approach in other, patients. And also we routinely do one session a month about very unusual cases, which made us scratch our heads how to treat these patients. So these are really very valuable, and I hope everybody will benefit from this session today. So Mahmoud, do you think we're ready to go?
Yes.
Okay.
You are ready? Okay.
All right. You have the... Thank you.
Thank you, Doctor. يعطيكم العافية. Today we'll present a case that was referred to our hospital before 2 months. We had a female patient. She was 23 years old with no past surgical history, with no non-drug allergies. She was single and doesn't smoke, lives with her family, and she doesn't have a family history of rheumatological disorders or any hematological disorders. Our patient had a past medical history of anemia. Her hemoglobin reached about 5.5 4 or 5 years before our admission. It was assumed to be due to iron deficiency anemia and had blood transfusions many times. And she was treated with symptomatically with iron replacement and blood transfusion as necessary. She had a transient improvement in her hemoglobin. It reached maximum 9.5 or 10 at its best. This transient improvement lasted about 1 year till 2017. Then she had investigations including whole body CT scan at 2017. It was unremarkable. She had lost follow-up with just taking iron replacement tablets by herself without visiting any doctors, with a stable hemoglobin, about 9 to 10 from 2017 till 2020. In 2020, she had again had follow-up. She had upper and lower GI endoscopy, which were also unremarkable. Then in 2021, she had presented to a governmental hospital in Kalkilia with a chief complaint of exertional shortness of breath of 1 month duration. On March 2021, she had presented with generalized arthralgia. It was symmetrical, most pronounced at proximal interphalangeal, metacarpophalangeal, metatarsusophalangeal, and knee joints. She had also a swelling and redness of mentioned joints. Morning stiffness was less than 1 hour. It improved during the day. She had also mentioned feverish sensation, but with no documented fever readings. She had also easy fatigability and skin rash upon exposure during the day. But there is no history of eye redness, ulcerations, oral or genital, hair loss, significant weight loss, or any finger discolorations on cold exposure. On 10th of June, she had started to have, in addition to the mentioned symptoms, and progressive shortness of breath. It was with moderate exertion and with daily life activities. Shortness of breath was not associated with chest pain, sputum, or hemoptysis. She had done CBC at that time and basic investigations in the ER, including CBC. It showed hemoglobin of 9.5 and chest X-ray showing massive left-sided pleural effusion. This X-ray from the referring hospital at that time. So we had an anemia and left-sided pleural effusion at the referring hospital about 10th of June. This is a lateral X-ray. Okay. There, she had left chest tube insertion with a drainage of fluid about 2 liters. Cytology was done from the aspirated fluid and was normal. Her shortness of breath had improved transiently with tapping of fluid. She had chest abdomen pelvis CT scan at that time. It showed also cervical, axillary, inguinal lymph nodes enlargement. The largest one was inguinal lymph nodes. She also had splenomegaly about 14 to 15 centimeter at the CT scan showing at that time. Let me play the CT scan. This CT scan from the referring hospital. Sorry, this is another view. Okay. So for now, they did a CT scan in chest, abdomen, pelvis showing multiple enlarged lymph nodes, splenomegaly. They inserted a chest tube. They aspirated about 2 liters, and that cytology that was normal. Okay. After 2 days of admission, after 10 days of admission, they had an inguinal lymph node biopsy, and later on histopathology showed non-specific reactive hyperplasia. They had done hemoglobin there dropped during hospital admission and reached 5.5. Workup also include ESR that was 105. Direct and indirect Coombs tests were also positive there. ANA and double standard test were also positive. They have done urine analysis showing RBCs, 10 RBCs and dysmorphic RBCs. Spot protein creatinine ratio was also done and was 1.9. Creatinine was normal, 0.6. She was admitted after about 1 week to our hospital in the 28th of June. On arrival, she had stable vital signs, but with mild elevated blood pressure. She had no fever, but had mild hypoxemia, about 92 saturation on room air. She was pale with decreased, and physical examination included decreased air entry on bilateral lung zones, especially left side. She had palpable liver edge, non-tender. There was also trace bilateral lower pitting lower limb edema. No skin rashes were noted at that time. There was tenderness over the mentioned joints before, including proximal, interphalangeal, metacarpophalangeal, and metatarsophalangeal joints. Our labs on admission at our hospital showed normocytic anemia. Hemoglobin was 5.1, MCV 83, lymphopenia, absolute lymphocyte count 590, RDW was increased, coagulation profile was acceptable, also electrolytes, creatinine was normal. Urinalysis in our hospital showed +3 blood, +2 protein with no casts. ESR was elevated to 141. C3 and C4 were in normal range. C4 was 0.04 and C3 0.2. Direct and indirect Coombs tests were also positive. LDH was elevated about 300. Total bilirubin 1, direct bilirubin 0.9. Liver enzymes, including AST, LT, was also elevated. D-dimer was 6.4, which is elevated in our hospital. Fibrinogen was low, 93. Hepatitis profile was done and also negative. Antiphospholipid antibody negative. Beta-2 glycoprotein, IgM and IgG were negative. Lupus anticoagulant was negative. Blood film at our hospital showed normal morphology of platelet, white blood cell, and RBCs, and no histiocytes or abnormal cell morphology could be seen. CT scan was repeated at our hospital showing bilateral effusion at the right side about 5 centimeter and 3 on the left side. There was also consolidations, mild pericardial effusion, and enlarged lymph nodes, including axillary, hilar, and mediastinal lymph nodes mainly. Abdominal ultrasound done at that time were also showing enlarged liver size about 18 centimeter, and spleen was mildly enlarged 14. Kidneys were normal on ultrasound. Echo, as the patient had pericardial effusion, was done and showed a ejection fraction of 55%, and it was unremarkable mainly. The patient during hospital stay had 2 bagged RBCs but transfusion, and she was started on methylprednisolone 500 milligram for 3 days, as she was assumed to have an active nephritis of active rheumatological disease, was not at that time diagnosed definitely, but was assumed to be an SLE. Tapering of steroids was also done. She was started on ARBs for her proteinuria, as she had flushing with use of enalapril. She was started on also hydroxychloroquine 200 milligram. And then later on, she had kidney biopsy at our hospital. Later on, it had showed diffuse proliferative lupus nephritis class 4. She was discharged from our hospital on mycophenolate mofetil, hydroxychloroquine, and tapering steroids with ARBs, mainly on valsartan. Follow-up after 2 weeks was done and showed a decrease in her protein creatinine ratio and proteinuria to 0.6, and she had improvement in her shortness of breath symptoms and fatigue, as well as in her joint swellings. And patient now followed up again after 1 month and was also in good general health. This is our case.
Okay, thank you. This is really very interesting case. So let's summarize, what's going on with this lady. So number one, she's a young woman, and
Yes.
certainly I agree with the diagnosis of lupus in this case, because she did have pleural effusion, which is serositis. This is one criteria. She
Yes.
did have lymphocytopenia and
Yes.
anemia, which is the criteria for hematological manifestation. She did have lupus nephritis, and actually this is the most important criteria item that we look for if you want to apply the 2018 classification criteria for lupus. So probably all of you are familiar with the old criteria that we use for diagnosis of lupus, which is the 1996 criteria. It requires 4 out of 11 items. There has been revision in 2012, 2018, and the most recent one is 2018. It requires positive ANA as entry criteria. So we should not classify any patient as lupus unless they are ANA positive. This is number one. Number two, there are a bunch of items you look at, mostly lab tests, complements, urine abnormalities, lupus nephritis, which has 10 points per C. And you need to meet this criteria 10 points at least. So just by having positive ANA and lupus nephritis on kidney biopsy, this is adequate for diagnosis of lupus. Okay, so again, just by having lupus nephritis and positive ANA, this is lupus, and this patient is presenting with lupus. Now, I have to remind you that these criteria, and any criteria in medicine in general, it's meant for classification purposes in order to get a homogeneous population to study, and that's for medical or clinical trials. It's not really for medical care of patients, but still it's valuable to apply this criteria whenever possible. Okay, so let's look again at the manifestations of lupus this patient had. So she had pleural effusion, and I would like to learn more about pleural effusion. what kind of pleural effusion was it? What was the LDH? What was um, uh, the pH for the pleural fluid? Because sometimes, and glucose, sometimes, this fluid can be complicated by infection, especially if this is long-standing diagnosis of lupus and the patient is immunocompromised because either of the illness that they have or because of use of immunosuppressive therapy, although the pleural effusion started before using immunosuppressive therapy in this patient. Also, this patient had skin rash. Would like to know what kind of rash is that? What's the distribution? Is it photosensitive over the face, arms, or does it involve other parts of the skin? Presence of pericardial effusion. It's, in fact, if you look at the X-ray again, it seems she has cardiomegaly, although this is portable X-ray, which mostly means that this is it was portable X-ray, right? It seems, because it's not really the best quality. So this could be, rather than posterior anterior X-ray, it could be anterior posterior, and that gives you wider mediastinum and increased the cardiac silhouette. In fact, if you look at the X-ray here, you can see there's right-sided pleural effusion with fluid in the fissure, the pulmonary fissure. Also, she did have, yes, indeed, she did have some atelectasis in the right lower zone. You can see this white plate-like structure. And if we look at the left side, although the costophrenic angle is still intact, but she has widespread opacity in the lung. So this could be some sort of loculated pleural effusion. And maybe we're confusing the left costophrenic angle with gas bubble in the stomach. But there's cardiomegaly also, and you need to consider pericardial effusion or cardiomyopathy in a patient like this. Lymphadenopathy, although it's not one of the criteria for diagnosis of lupus, but certainly it's an important manifestation, especially in young people. And usually these patients do not do well when they have lymphadenopathy and lupus. All right. So this is really very definitive diagnosis of lupus, in addition to positive ANA, positive double-stranded DNA. Now, my comment about her anemia, we need to know if she has underlying hematological disorder other than lupus. Specifically, if she has thalassemia trait. Because usually, this patient had the anemia for years, it appears, before the diagnosis of lupus. And inflammatory anemia, or what we called it before, anemia of chronic disease, usually it falls in the range of 8 to 10 hemoglobin gram per deciliter. If you have a patient with hemoglobin less than 8, consider an alternative diagnosis. Usually, again, inflammatory anemia or anemia of chronic disease, the hemoglobin will be between 8 and 10. It rarely drops less than 8. So it's important to look if she has, thalassemia trait, although looking at her most recent CBC, it seems her MCV was 83, which is not consistent with thalassemia trait, but we don't have CBC before this happens, which may reflect if she has underlying hematological disease. Now, for her, direct and indirect Coombs tests are positive, which may indicate hemolytic anemia. The best test for hemolytic anemia will be haptoglobulin for these patients. Haptoglobulin, it's an acute inflammatory marker, but usually in somebody with hemolytic anemia, it will be low, okay? So haptoglobulin can help you in identifying if this is hemolytic anemia or not. And peripheral blood smear. Thanks for sharing the result of peripheral blood smear, because my concern will be either hemolytic anemia in this patient, or TTP is an alternative diagnosis, as it can present with renal failure, kidney manifestations, and fever and seizure, or neurological manifestations, as you know, the criteria for TTP. And interestingly, there's overlap between lupus and TTP. Minority of patients with lupus may have this overlap. So getting peripheral blood smear is very important in a patient with lupus who has anemia. So overall, I think this patient received excellent care. I would recommend to do the kidney biopsy much earlier, and I understand there's logistics about getting the kidney biopsy, and it's not something that is done routinely in most of our hospitals back home, especially the interpretation of the pathology results. Just limited, opportunities for that. But the moment you think of lupus nephritis, you should obtain kidney biopsy. So ideally, this patient should have received the kidney biopsy or had the kidney biopsy in June, when she first presented with proteinuria. So presence of proteinuria, if there's more than 0.5 gram per 24-hour urine collection, or if the spot urine protein over creatinine ratio is more than 0.5, because there's, as you know, correlation between proteinuria and the spot urine. So ideally, when you see that proteinuria, or when there's increase in creatinine, or if there's active sediments in the urine, like red blood cell casts, white blood cell casts, or dysmorphic red blood cells in the urine, next step is immediately get kidney biopsy, because you are looking exactly for class 3 or class 4 lupus nephritis. And in this patient, it was confirmed that this is class 4. So the treatment for class 3 and 4 is different from the other classes. It's usually responsive to treatment compared to other classes, but if you don't treat it, patients may end up with renal failure. So treatment of class 3 and 4, we do the same approach as you did here, by using steroids. And induction therapy should be one of two options for these patients: cyclophosphamide and mycophenolate. cyclophosphamide, it used to be the gold standard treatment, and there are protocols about using it 500 milligrams every 2 weeks for 3 months. This is one of the approaches for treatment, or monthly doses of cyclophosphamide. The issue about cyclophosphamide, especially in young women like this lady, is infertility, and it's serious risk. You're talking about 10 to 20% risk of infertility, if not more. If we have to do cyclophosphamide, we usually pre-treat these patients with leuprolide, which is gonadotropin releasing hormone antagonist, in order to preserve her ovaries from ovulation and from exposure to cyclophosphamide. The better approach is mycophenolate. And I think this patient probably received myfortic rather than mycophenolate mofetil, because the dose is on the low side, 180 milligrams. The mycophenolate mofetil, the dose is usually 1,000 milligrams twice daily, and consider increasing it to 1,500 milligrams twice daily. So I think she had the other form of mycophenolate, and the dose is 180 to 360 milligrams twice daily. Now, this patient, it seems she is going to achieve clinical remission from lupus nephritis because her proteinuria is improving. But we have to see that her proteinuria drops less than 0.5 grams per day. This is very close, 0.6. There's an option for patients who still did not achieve clinical remission by improving in their kidney function or proteinuria less than 0.5 milligram, which is voclosporin. And the trade name is Lupkinsis. It's a recently approved FDA medication for treatment of lupus nephritis. It was approved within the last 12 months. And so it's like cyclosporin, but it's modified in a way it's less nephrotoxic. And certainly these patients want to be careful, you know, in terms of using nephrotoxic medications. So these are the teaching points, I think, from this case. Whenever you think of lupus nephritis, obtain kidney biopsy looking for class 3 and 4. Lupus is multisystemic disease, as you have seen in this case, you know. It affects multiple organ systems. She had hematological manifestations, kidney manifestations, skin disease, arthritis, lymphadenopathy, pericardial effusion. You know, it's multisystemic disease, and it's not just limited to one organ. That's why we need to keep an open mind when we're dealing with these patients in order to identify exactly what's going on with them. Now, one more thing I would like to keep in mind is that patients with a rheumatological condition, they can manifest with hemophagocytic lymphohistiocytosis or macrophage activation syndrome. And this could be a cause for anemia, abnormal liver function test, cytopenias. Usually the treatment is directed to the underlying disease, but always think of macrophage activation syndrome in somebody who is really sick, not responding to the treatment for the condition that you are dealing with. So this could be secondary to infection or secondary to rheumatological conditions like lupus, or it can be familial hemophagocytic lymphohistiocytosis. So going back to the teaching points, proteinuria, abnormal casts, increased creatinine, you should have very, very low threshold for getting kidney biopsy on these patients. Treatment, mycophenolate and steroids for class 3 and 4, and consider voclosporin. Consider macrophage activation syndrome in these patients, and look for TTP in somebody with anemia, especially with a thrombocytopenia, but this patient did not have that, and obtain peripheral blood smear as this patient peripheral blood smear did not show schistocytes or fragmented red blood cells. And keep in mind, most patients with lupus, they will have positive serologies. The most common is ANA in 95% of patients. But some patients will have negative ANA, which means 5%. The majority will have other serologies like Smith antibody, which is very specific, or double-stranded DNA, or if they have really convincing clinical presentation, something specific like lupus nephritis or Miller rash, that may qualify as seronegative lupus. All right. So I'm done with my overview of the case. Again, she received excellent care, and here we are commenting about diagnosis. This is definitive lupus, no doubt about it. Definitive lupus nephritis, and treatment is steroids and mycophenolate. Now, do you have the kidney biopsy pathology report description?
Actually, we have. I just included the conclusion. Sorry. That she has a diffuse proliferative lupus nephritis, class 4. I didn't include the description, unfortunately.
Basically, what they will describe let me see if I can share with you some images. Just give me a second to find the presentation about lupus.
But what is the name of the recently approved drug for SLE nephritis again?
Voclosporin, VOCLOSPORN. So it's like cyclosporin, but it starts with voclosporin.
Voclosporin.
Yes. Recently approved, but I don't think it's widely available yet. Okay. Let me see. Is it possible to allow me to share the screen?
From the host, we can allow you. This is our. It's not.
Let's see. Yeah, I cannot share the screen. But there are certain features on the kidney biopsy that we look for to identify if this is lupus nephritis. Number one will be the immunofluorescence. So usually in these patients, you'll see what we call it full house disease. What does that mean? It means whatever immunofluorescence test you do, it will be positive. So if you stain for IgG, if you stain for complements, everything will be positive. That's the full house, and it's classical for lupus. This is important immunofluorescence because it will help you to differentiate between lupus and vasculitis involving the kidneys, because both of these conditions may present with crescents and the glomerulus where there's inflammation. Immunofluorescence will be negative in vasculitis, and we call that posi-immune, which means very few immune complex deposition. In lupus, it will be full house. Everything is positive. And the other feature is inflammation in the glomerulus with crescent formation. This is class 3 and 4. And the difference between 3 and 4 is how much glomeruli are affected. If this is less than 50% of the glomeruli on the biopsy specimen, this is a class 3. More than 50%, this is a class 4. This is the only difference. But if you look at the individual glomeruli, it will look the same. There's inflammation, sometimes crescent formation, localized to the glomeruli with positive immunofluorescence as full house. All right, any questions about this case? Now, let me ask you, the pleural fluid, clearly the CT scan subsequently it's showing bilateral pleural effusion. And this is more likely to represent, systemic disease. Because if you think of PAMA, for example, usually it's unilateral, and usually it's secondary to pneumonia. So having bilateral pleural effusion, it tells you systemic disease, whether nephrotic syndrome, lupus, FMF, these conditions, systemic conditions. So do we have analysis on the pleural fluid?
Pleural fluid was taken from the referral hospital, not at our hospital. The results of the LTH and glucose and protein was not in the report, but they told us that it was transudative effusion and cytology done there showing normal cytology. But we didn't have pleural fluid analysis at our hospital.
Yeah. It could be transudative effusion, and it can be exudative in lupus, both. Transudative, especially in people with lupus nephritis, especially if they have nephrotic syndrome with proteinuria as anasarca. And certainly this patient had also ascites, and he had peripheral lower extremity edema as you described. So I think this is part of the nephrotic syndrome. Keep in mind, patients with lupus are at more risk for pulmonary embolism and DVT. So thromboembolic disease is another factor for shortness of breath and for pleural effusion. And usually it is exudative pleural effusion after pulmonary embolism, especially if there's pulmonary infarction. Yeah, that's interesting. I think it's more with the anasarca as a manifestation of nephrotic syndrome. Now, I want to comment on shortness of breath in general. I find this really very interesting. Shortness of breath in general, it's common, and actually one of the most common symptoms if you ask your patients about. Most of the time, shortness of breath is not related to pulmonary disease. Most of the time, it's related to, number one, deconditioning, especially in elderly people who get in the hospital. They stay for a few days, they lose their strength. And when they try again to go back to the same level of activity, they are deconditioned. So deconditioning is one cause. Number two, weight gain. And in fact, these two are the most common causes of non-pulmonary causes of shortness of breath: weight gain and deconditioning. Medications like steroids or NSAIDs can cause GI bleeding, for example, and iron deficiency anemia. So anemia is another factor, and this patient has anemia. I would say likely her initial manifestation of shortness of breath before having pleural effusion was related to anemia, but also lung disease such as parenchymal lung disease, acute pneumonitis in lupus, or interstitial lung disease, which is not very common in lupus, but still it can be, or alveolar hemorrhage as a manifestation of acute pneumonitis. These are things to consider as pulmonary manifestations. So we think of shortness of breath as non-pulmonary causes. Number one, deconditioning. Number two, weight gain. Number three, anemia. Number four, heart failure. Five, pericardial disease in general. Number six, cardiac disease in general. And then pulmonary manifestations. Think of it as parenchymal lung disease, interstitial lung disease, alveolar hemorrhage, pneumonia, anything filling the alveolar space and impairing oxygen transfer. And then think about something from outside the lung, such as a pleural effusion for any cause. Then think about the chest wall, limited mobility. Things like systemic sclerosis and myositis can cause that. So just keep in mind, shortness of breath could be, a manifestation of more broad disease than just a disease limited to the lung.
Dr. Nizam, thank you for these informations. I want to ask if the lupus affects the kidneys and isolated kidney involvement. Then how can we differentiate between primary membranous nephropathy and lupus nephritis? Or the treatment will be the same in these two conditions?
Excellent question, thank you. So yes, you are right. Lupus can affect the kidneys with no other organ or system involvement, just limited to the kidney. Although it's rare, because as we mentioned, 95% of patients will have positive ANA. So if you have positive ANA and some kidney disease like proteinuria, you need to consider lupus nephritis in these patients, and obtaining kidney biopsy will confirm that. But you're right about this question. How about if ANA is negative, nothing else is positive? We have kidney biopsy for somebody with proteinuria or renal failure or active sediment. So it will be either primary glomerulonephritis, something like membranous minimal change disease, focal segmental glomerulosclerosis, It depends on the biopsy, or it could be still the same, pathology, minimal change, membranous glomerulonephritis, mesangial proliferative glomerulosclerosis, secondary to lupus. How to differentiate between the two conditions? Number one, for membranous disease, if this is a primary disease, there's a specific antibody that you can do in the blood. It's the anti-phospholipase 2, I think, APL 2. I think, it's recently approved antibody, and it's very sensitive and specific for primary membranous glomerulonephritis, not secondary to lupus. So if it's positive, it will tell you primary. Number two, immunofluorescence. Usually immunofluorescence is not full house in these conditions. There might be some immunofluorescence deposition, but it's not a full house. Usually full house means lupus nephritis rather than a primary glomerulonephritic disease. So immunofluorescence is the second point. Lupus nephritis is treated in a little bit different way, especially if we're dealing with proliferative glomerulonephritis class 3 and 4. The standard of care is either cyclophosphamide or mycophenolate. Whereas primary glomerulonephritis, they may not be responsive to treatment in the same way as lupus nephritis, number one. Number two, we have to look for underlying conditions, especially if you're dealing with membranous and minimal change. There's association with malignancy in these patients, especially elderly disease. So you have to look for underlying malignancy. Excellent question. Thank you.
Thank you.
Thank you, doctor.
Thank you. All right, Mamoun, you did great today.
Thank you, doctor.
Excellent presentation. You put a lot of effort to put it together. So I congratulate you for this presentation. Thanks for sharing it with everybody. I think, we learn from our patients. And I encourage you, and probably, your mentors there encourage you to do patient-oriented reading for a reason, because I'm certain you'll remember this case for years and decades to come, and you'll apply the knowledge you learned when you reviewed this case on other patients. Whereas if you are reading for the medical school exams in An-Najah, or if you're reading for USMLE, usually we know the lifespan of this knowledge that you gain is somewhere between a few days to maybe a few months at maximum. But you'll be able to retrieve an information that you read about a patient many years or decades later. So always do your reading based on cases like this. It's really useful to build your knowledge and maintain it for a while. All right, great. Thank you. I enjoyed very much the presentation and the company of this group. Thank you. Thank you. Take care, everybody. Assalamu. Thank you.